roll for a while, and then I'll pause as we go.
Okay. I think it's ready. All right, let's hurry up, man. Okay, hurry up. Here, I'll tell you what to do. No. I ain't you're gonna give it a shot. You're gonna give it a shot. I ain't giving it a shot. I never done this before. I ain't never done it before either, all right? I ain't starting now. Look, you brought it here, and that means that you're gonna give it a shot. The day that I bring an OG miss to your house, then I give it a shot. Give it a shot. Give it here. Give me that. All right, tell me what to do. Okay, you're giving her an injection of adrenaline straight to her heart, but she's got a breastplate. You gotta pierce through that. So what you gotta do is you gotta bring the needle down in a stabbing motion. I gotta stab her 3 times? No, you don't gotta stab her 3 times. You gotta stab her once, but it's gotta be hard enough to get through her breastplate into her heart, all right? And then once you do that, you press down on the plunger. Okay, then what happens? I'm curious about that myself. This ain't no joke, man. Am I gonna kill her? No, she's supposed to come out like that. It's... All right, count to 3. All right, ready? 1. 2. 3. If you're all right, say something.
Something.
Who's seen that movie before? Okay. When you first place your first implants, it feels like that, doesn't it? There's something about it that's similar to placing your first implant. You've got the right spot and you think this is going to work, and then you're not sure what your nurse is looking at, and you see this freaky person in the background freaking out. That's what it's like. And when you're placing 10, like Joe's doing, I think it would get even more intense. So some of these ideas that you'll see are going to help to sort of make that a bit easier, so you can take a step further forward, really, in a more controlled manner. So what basically happens is the patient comes in, you get an impression of their mouth, and you send them to the lab with the impression. You can sort of, have you guys all got this brochure? So an impression of the patient's mouth is taken in a special type of tray. Hopefully you should have them on the front, if you can just pass them back. The tray's got a radioactive type of substance in it that will be picked up on the cone beam, right? So, and if you can see closer to the front, there's little markers on the tray, and they'll come handy in a little while once you see how that gets put into the software. So the patient gets an impression, and then what takes place is you surgically you use your software to put your implant where you want it to be, away from things and exactly in the position you want it to place. So often with a Mini, you don't have the same issue of where the top is, unless you've got these pelvically placed ones that we were discussing before. If the implant's not exactly in the right place, you can make up for it with the way the crown's made, right? Whereas if you're placing a standard implant, it's a lot more complicated, I think. Getting it in the right place becomes very, very touchy when it comes to ginger in delicate places, especially anteriorly. And even for these bigger cases, so if you've got a full arch case and you've got your implants that aren't angled the right way, when you place your screws, if you're going to have a retrievable screw type of situation, then you need to get the implants in pretty well right on, otherwise you're in real trouble. So you've designed the placement of the implants on the computer. You've then transferred that information so you've designed it you've worked out where the bone is and your nerves and all that jazz. You then place it into the CAD machine. It'll drill where the implant's going to go. So you can see that we've been trying this with a Mini, and we had some troubles, and we'll talk about that in a second. it's because the thickness of the tray was too big, and so your implant, your drill that goes through to get your pilot in, was not deep enough to engage in the bone. So we're coming up with some other solutions, and I think Joe's surgical guide's a lot easier to use than this one. But with a standard implant, because they're special surgical kits, you can actually do it with a standard. So you'll see it here for a so it's the mini hole. So the sleeves get put into the CAD drills, and then your surgical drills are designed to give you, here we go, I've even placed, this is the Pulp Fiction scene, where we place the guide over the patient's mouth. We wanted to have an idea of where the implants were going to go and see if they were going to be, did the guide actually, was it correct, was it close at least? So I've just marked the spots through the holes with one of those indelible ink spots, and you can see that it's approximately, it looks like it's going to be in the right place where all the implants will go through. And these are guides here. The drills are made so that they're quite long. You could have a 27mm drill, and it has a stopper at the top, so as it hits the top of the guide, you can't drill any deeper than the stopper. So this is totally blind, of course. You're not opening the flap up or anything like that. And the way that you control the position of the guide, so the drills are quite long. You can see there in the back. So what happens is, of course, if you put the guide in the mouth, it'll slip around, won't it? So you place these locks in, and you've designed those also so they obviously engage in bone between the implants. Once you've basically nailed those in position, you can then drill straight through the guide. Your drills won't let you go any further than the depth of the drill that you've chosen. So you could have a 27mm drill, 20 to 15, depending on how far you want to go through the impression tray. So the impression tray might be 10mm, your drill might be 27, so you've got 17mm beyond it, right? So you can pretty closely, like down to 0.5mm, engage how far you're going to drill through to place your implant. And those two pins at the front, you're not going to let that move around. So you're in control there. And you've got a totally closed procedure, so you don't have the more complex surgical steps that are involved in a full open technique. So then you'll first do a tissue punch. Took the guide out to see how it was. You can remove the tissue just so it's simpler. I don't think you really have to, really, but it's probably needed to. And then you're using these spoons that are similar to the one that we use for the mini implant when you've placed is anyone using these guides at all? You know what I'm talking about? So when you,
Drill guide.
Sorry?
You're talking about the first pilot drill guide.
Yes, the first pilot drill guide. So when you've got a surgical guide, you put a spoon inside the guide and you drill through that because, of course, the hole is too big. Your drill would be bouncing around. This controls the position of the drill. This does the same thing. So this is a 2mm one there. We're placing a 3.8mm implant. So obviously it'll get bigger and bigger as you go through the series. Then you'll even place the implant through the guide because you've grabbed the osteotomy, it controls the position of the implant. You can see the placement's pretty neat there. Then you put your attachments on. You've got your acrylic denture over the top and you'll start adjusting things. respect the bite and all that jazz. So what I find is with the larger implant, it's obviously more difficult to get the parallelism occurring. With the mini, I've done full roundhouse cases. I don't think it's such a big deal. You're not so surgically, you don't need to be as in control of parallelism as opposed to with a standard. I think it's a lot more complicated because there's so many parts, things don't line up, it makes it harder to get everything looking good at the end. There's a motivator, of course. You've got 4 daughters, you've got to keep drilling. You want to eat, and of course the best part is my father's birthday, got to drink some nice port. And this is the thing that you've got in your hands. So it gives you a snapshot of what's going on. Just some thanks to some people here. So I think the discussion for me really is, I think if you're using a standard implant, you really do need more control. Whereas with a mini, I've found that, I think it's a lot easier placing a mini implant than a standard. And this technique really has made standard implants a bit easier and less surgically invasive. So of course, if you raise a flap, you're losing bone. If you can do a fully closed procedure, the patient doesn't have all the post-op issues like we've discovered with our mini implants. They have very little post-op pain. Whereas as soon as you're raising a flap, there's always more issues. So these surgical guides are really helping us to get more parallelism, which I think is less of an issue with minis. And we've been trying to get the surgical guide to work with the minis, but we found it difficult. So we sort of want to open up a discussion as to how we could use an impression technique, which we're used to using in everyday dentistry, to produce a surgical guide instantly. Yeah, that's pretty well what we've been working on in the last few months.
Who's placing the sleeves after you planned your computer planning?
Yeah.
On that impression? Who puts the sleeves in the same way the computer planning was?
Yeah.
Because that's where your inaccuracy is going to happen.
Correct. Yeah.
Plus your impression material is a rubbery material, so
yeah.
you have inaccuracies in that as well. On the amount of pressure you place in, there's quite a bit of leeway there. Whereas when you're doing a proper surgical guide made by a company, it's a rigid material and it's printed. So the inaccuracies in your positioning of that surgical guide in the mouth is minimized.
Yeah,